The jet ventilator works in tandem with a conventional ventilator. While the conventional ventilator provides a bias flow through the ventilator circuit, the jet is providing very small, fast pulses of gas. The jet ventilator utilizes extremely short inspiratory times and high-flow gas pulses to ventilate with low volumes and low pressures. The life port adapter is placed as close to the patient as possible at the end of the ventilator circuit and attached to the endotracheal tube. The jet port and pressure monitoring tube are connected to the patient box, which sends information back to the jet ventilator. The patient box is an instrumental part of jet ventilation. As fresh gas is pushed from the jet ventilator, it travels to the patient box. The patient box contains a pinch valve which will interrupt gas as it flows through the jet line at rates of 200 to over 600 times per minute. Because the flow is interrupted and not pulled from the lungs, exhalation is controlled by elastic chest recoil, making it passive exhalation. Gas then travels down the jet circuit where it enters the life port adapter, which is responsible for creating the jet pulses. The life port adapter has a jet port which allows the jet pulses to be delivered. There is also a pressuring monitoring port that sends information back to the jet ventilator, which displays multiple values. As fresh gas travels down the line to the life port adapter, the Bernoulli effect causes changes to the flow of gas. As the slower, higher pressure gas in the large tube enters the orifice, whereas the diameter of the tube is reduced, the gas increases in speed while the pressure decreases. These high-speed, low-pressure pulses travel through the life port adapter and travel down into the patient's airway. As the high-speed jet pulses enter the lungs, they form an air stream in the center of the tube. The air streams penetrate the dead space instead of pushing it further down into the airway. The penetration causes the dead space and carbon dioxide to move to the outside of the gas stream and against the airway wall. The dead space and carbon dioxide are passively exhaled in a bidirectional double helix pattern. Since the tidal volume is less than anatomical dead space, the impact of dead space on ventilation is minimized since it is continuously flushed out. The gas pattern is also useful in patients with air leaks. Since the high-speed gas stream is traveling through the center of the airway, it bypasses any areas of air leaks. This prevents gas from leaking out through the damaged area of the lung and allows the injured area to heal. Taylor dispersion explains the interplay between convection forces and molecular diffusion. As high-flow fresh gas pulses are sent down the airways in a convective stream, the stale or slow-moving exhaled gas is displaced to the outside of the fresh gas stream along the walls of the cylinder, in a swirling motion called a double helix. This allows the jet pulses to penetrate deeper into the bronchial tree, allowing for ventilation of the distal alveoli, while minimizing the effect of dead space gas. Some of the fresh gas mixes with gas present in the alveoli, allowing for gas exchange with very low tidal volumes. During conventional ventilation, larger volumes of gas enter the alveoli, causing large volume and pressure swings. During jet ventilation, the lungs are inflated to an optimal level and very small and frequent pulses of gas maintain the alveoli in the open position. The high-frequency jet ventilator is a unique ventilator modality that offers numerous physiological rationales that may optimize ventilation and minimize the risk for mechanical injury in premature lungs. Understanding the physiological concepts is essential for optimal decision making to maximize the benefits and minimize the risk for harm. However, many clinicians lack training and experience with the equipment. Hopefully this video provides some insight into the jet ventilator. On the oscillator ventilator, the piston will push and pull gas through the lungs. This means that the inhalation and exhalation are active, or being completely controlled by the ventilator. Since jet ventilation provides breaths at extremely high rates, inspiration and exhalation occur simultaneously. Airway resistance also determines how inspiratory gas is distributed in the lungs. The inspiratory gas must overcome the elasticity of the lung units, and airflow will always follow the path of least resistance. The faster the inspiration, the less gas will enter lung units with high resistance or low compliance. This prevents lung units that are damaged or narrowed to experience high pressures, such as alveoli damage from pulmonary interstitial emphysema. Jet ventilation can be described as an open lung technique of ventilation, as it aims to maintain an adequate mean airway pressure that allows the alveoli to maximally participate in gas exchange while preventing collapse and overdistension and the resulting alveoli damage. The pressure-volume loop can be used to represent this idea. In a normal lung, as pressure is applied to the lung, the alveoli will inflate and fill with a volume of gas. This graph also shows compliance, which is the change in volume divided by the change in pressure. This can also be thought of as the change in volume that occurs due to the change in the application of pressure and demonstrates the ability of the alveoli to stretch and expand. If too little or too much pressure is applied to the alveoli, it can result in damage, such as pulmonary interstitial emphysema or bronchopulmonary dysplasia. This occurs when ventilation is inadequately low, or the mean airway pressure is below the critical opening pressure. The critical opening pressure or lower inflection occurs when there is a drastic change in slope of the inspiratory limb of the loop. This point reflects when there is a rise in the number of alveoli being ventilated. It also shows the point at which the minimum amount of pressure required to inflate the alveoli is surpassed. If too little pressure is applied, the alveoli may partially or completely collapse. When the pressure is applied to inflate the alveoli, it can create shear stress. The upper inflection point is when the slope of the inspiratory limb decreases, and can be considered the point of overdistension. This point indicates that the maximum number of alveoli are inflated and nearly at the maximum volume. As the slope indicates, any pressure applied beyond this point will result in minimal volume return. Ventilating at pressure beyond this point may result in barotrauma, one of the most frequent complications occurring in mechanically ventilated infants, and lead to bronchopulmonary dysplasia. It is also important to notice that after the alveoli are opened, it requires less pressure to maintain them in the open position. If a line is placed at a pressure of 8, the inspiratory or opening side of the curve is just beginning to open and fill. After it has been filled with air, the same pressure maintains a great deal more volume at the same pressure. Preventing the collapse or inhibiting the elastic recoil to a slight degree will maintain the alveoli in the open position with an optimizing mean airway pressure. Applying excessive pressure to the lungs creates a high risk for lung damage to occur. Applying too little pressure also leads to lung damage. Ideal ventilation maintains a mean airway pressure between the lower and upper inflection points and optimizes ventilation and perfusion matching and functional residual capacity. In conventional mechanical ventilation, the pressures and volumes may be large, compared to high-frequency ventilation, leading to large swings in pressure. This may result in inadequate or excessive pressure being applied to the lung, resulting in damage. High-frequency ventilation applies an optimal mean airway pressure that is set at a pressure that maximizes alveoli recruitment while avoiding over or underinflation. The jet ventilator utilizes extremely high respiratory rates. The starting rates range from 240 to 660, but rates over 540 are rarely used. This table represents example starting rates based on the patient. Rate changes are usually performed by 60 breaths per move or 1 Hz. Patients with air leaks are ventilated with lower rates, ranging from 240 to 360. Higher rates of 420 to 540 are used to decrease carbon dioxide levels when the patient remains hypercarbic despite increases to PIP without evidence of air trapping. The jet ventilator delivers respiratory rates ranging from 240 to 420 breaths per minute. The inspiratory time is set at a standard 0.02 seconds or 20 milliseconds, and should not be manipulated as it may lead to air trapping. If the inspiratory time is increased, the rate should be decreased to prevent air trapping. As respiratory rate increases, the expiratory time decreases. Carbon dioxide elimination is controlled by the change in pressure, or delta P. This is calculated by subtracting the peak inspiratory pressure and PEEP and represents the delivered tidal volume. However, the peak inspiratory pressure on the jet ventilator should not be thought of as the peak inspiratory pressure on the conventional ventilator, at least in terms of the risk for lung damage, as the inspiratory time is very brief, resulting in a very small tidal volume being delivered. The jet ventilator administers breaths at a volume that is below anatomical dead space. However, the high frequency of breaths and Taylor dispersion forces allow for a high amount of dead space to be cleared from the lungs. When this occurs in the presence of optimal mean airway pressure and maximal ventilation perfusion matching, there is a significant elimination of carbon dioxide. When a patient is converted from conventional ventilation, the PIP on the jet should be set 2 to 4 above the PIP on the conventional. The higher end can be used if the infant is not responding as expected. Even small changes in tidal volumes may result in large changes in carbon dioxide elimination. The peak inspiratory pressure should be titrated to achieve the desired level of carbon dioxide. Changes in the delta pressure can change the arterial carbon dioxide levels approximately by the values in this chart. When manipulating the peak inspiratory pressure, or PEEP, it is important to remember that changing either value can change the delta pressure. If the patient's carbon dioxide level is good, PEEP primarily controls the mean airway pressure and thus oxygenation. Utilizing an optimal level of PEEP minimizes the risk of lung damage from both under and over alveoli distension. If the oxygenation is a problem, the PEEP can be increased, which will directly increase the mean airway pressure. However, if carbon dioxide levels were acceptable and the PEEP was increased, it could result in inadvertent changes in carbon dioxide levels. The initial PEEP is set at 6 to 12. If the patient is converted from conventional ventilation or the oscillator, the PEEP is set at 2 to 4 below the mean airway pressure, then adjusted. When changing the PEEP or PIP, consider how these changes affect the mean airway pressure and delta P. If the manipulation results in a change in the delta P, then ventilation will change. If the manipulation causes a change in mean airway pressure, oxygenation will be impacted. For example, a blood gas reveals a low carbon dioxide level, and the tidal volume is to be weaned. In this example, the peak inspiratory pressure was decreased, while the PEEP remained unchanged. This resulted in a decrease in the delta P and increase in carbon dioxide. However, it also reduces the mean airway pressure, which will decrease oxygenation. With the same patient, the peak inspiratory pressure was decreased, and the PEEP was increased. This caused an equivalent change in the delta P, which would cause the desired increase in carbon dioxide, but the increased PEEP ensures that the mean airway pressure remained constant. The servo is a numeric representation of the flow through the jet circuit needed to establish and maintain the set peak inspiratory pressure. Instead of being set, the servo is a feedback display and can be used to represent changing lung dynamics. When the jet ventilator is initiated and the patient is stabilized, the jet ventilator will enter a learning mode and determine a baseline servo pressure, which will be displayed. There may be small fluctuations in servo pressures as the patient spontaneously breathes. Trending the servo measurement when no adjustments have been made to the settings can indicate changes in lung compliance and resistance. The jet ventilator will alarm high or low when there is a change of more than 20% above or below the baseline servo. An increase in servo pressures indicates that more flow is required to fill a space at the same peak inspiratory pressure. So, this means that for a given pressure, more volume is being delivered. This may mean that lung compliance is improving, or there is a leak in the system and gas is escaping. A decrease in the servo pressure indicates that less flow is required to fill a space at the same pressure. So, this means that for a given pressure, less volume is being delivered. This may indicate that lung compliance is increasing, or there is an obstruction in the system. The jet ventilator works in tandem with a conventional ventilator. While the jet ventilator is administering pulses of fresh gas at high rates, the ventilator maintains a bias flow through the ventilator circuit and PEEP. This allows for spontaneous breathing, which is very beneficial for the continued development of the respiratory system in the preterm infant. The conventional ventilator can be utilized to administer sigh breaths at a rate of 2 to 5 breaths administered at 6 to 8 above the PEEP with an inspiratory time of 0.35 to 0.5 seconds. These are administered to help recruit alveoli and optimize gas exchange. The application of sigh breaths is an art that requires careful attention, as it can lead to volume trauma. Thinking back to the pressure-volume loop, it takes a high amount of force to open alveoli, but much less to maintain them in the open position. This approach can be exploited when a patient is first placed on the jet ventilator. When jet ventilator is initiated, the patient may be experiencing underinflation and atelectasis. So, when first started, a few sigh breaths should be added to recruit as many alveoli as possible quickly. After adequate recruitment is achieved, the sigh breaths can be weaned down or removed. If the patient is receiving the jet ventilator and continues to experience atelectasis, sigh breaths could be applied as part of a recruitment treatment. With this strategy, sigh breaths could be added for a few hours to optimize recruitment, then removed to reduce the risk for volume trauma. The high-frequency jet ventilator is a unique ventilator modality that offers numerous physiological rationales that may optimize ventilation and minimize the risk for mechanical injury in premature lungs. Understanding the physiological concepts is essential for optimal decision making to maximize the benefits and minimize the risk for harm. However, many clinicians lack training and experience with the equipment. Hopefully this video provides some insight into the jet ventilator.